meeting is being recorded.
So we are live on YouTube as well as we have started the recording. So this is Ranjit Sahu, Marketing Head with Walter Bushnell. So welcome you all to this webinar. UP State Chapter AGOI cordially invites you for an interactive webinar on the topic of tumor board meeting. So with this, I call upon Dr. Priyanka Singh, she is Joint Secretary UPSC AGOI Committee. Ma'am, over to you to take it forward, ma'am. Hello. Ma'am, you have to unmute and speak.
This is getting muted on its own. I'm sorry about that.
You have to unmute and speak, ma'am.
So I welcome all office bearers of UPSC AGOI, our experts from Lucknow and outside, and all delegates and panelists who have joined us for this UPSC State Chapter online tumor board meeting on a very relevant and pertinent topic of preserving fertility in gynecological cancers. We have two very interesting cases lined up, and we hope that our experts and panelists will help us deliberate and enlighten everyone about why and how we can preserve fertility in women who suffer from malignancies of the genital tract. It is relevant because a lot of cancers are occurring at a younger age. All of us are having patients in our OPDs who are coming at an age where they want to bear children, or if not, at least preserve their fertility for a better future and life. And also because a lot of malignancies, a lot of women are starting to bear children at a later age where certain cancers are common. So the topic is important and we should start on it. So to start the session today, I would humbly invite our president, our dear Professor Saroj Singh ma'am, President of UPSC AGOI.
Thank you, Priyanka. A very good evening to all of you. It gives me great pleasure to welcome you all in this tumor board meeting organized by UPSC AGOI on fertility preservation in gynecological cancers. Thanks to the improvements which have occurred in the field of gynecological oncology, so that we are now discussing what to do for fertility preservation, because prognosis has improved to such an extent that now we are worried about fertility preservation also. Although on one hand, we are facing the cases who are having the childbearing at the later age and they want the fertility issue also when they are cancer survivors. On the other hand, in the field of ART also, we have a lot of advancements so that we can give them real hopes also, whether it is sperm cryopreservation or oocyte or embryo cryopreservation, or we are doing conservative surgery like being less radical, whether it is by trachelectomy or by conserving ovaries in these cases. But overall, we are worried about the fertility, although a lot of guidelines have also come regarding this. But when we are dealing with the individual cases, we are worried because there are so many queries, there are so many controversies. So we have a very expert, experienced board of panels with us who can solve our issues and give us enlighten us regarding how to manage these cases. So I welcome our panelists, especially our guest panelists, especially Dr. Anita Agrawal from Canada and Dr. Rupinder Sekhan from Rajiv Gandhi Institute, who is our secretary also of the AGOI. And we have also listened her so many times. They will solve many of issues. I thank our chairpersons, Dr. Hem Prabha, Dr. Kiran Pandey, who is vice president, for being with us. And I also welcome our guest faculty, Dr. Shalini, Dr. Isha, Dr. Bhavna, to give their inputs in their specialty, what they are going to do. And of course, our young brigade, Dr. Saraswati and Dr. Priyanka, who are going to present these cases. I'm sure that this discussion is going to be of great benefit to all those who are practicing only gynecology or to all those who are practicing gynae oncology, and how to solve their issues, how to counsel them. It will be of great help to us. Before we start our meeting, I just want to pay my heartfelt condolences to one of our very active member, rather than is our treasurer, Dr. Amrita, who lost her husband only last month only in our UPCOG annual meet which we have. So we are really very concerned about her, and we pray that she and her family can be, may God give her courage to bear this terrible loss. So I think we can hold over to Priyanka.
Thank you so much, ma'am, for that kind introduction of everyone, and welcome to the whole gathering here. I now take the opportunity to introduce our dynamic secretary, Professor Nisha Singh, ma'am. A few words from our secretary, and who is also office bearer of the AOGIN and the AGOE Executive Committee. Ma'am is guiding us currently with a lot of enthusiasm. She is the professor in the Department of Obs and Gynae.
There is no need for our CVs. Please remove this.
Okay. So, आप मैम
इसको हटा दीजिए, please. Okay. So it's my proud privilege to be welcoming you all as the secretary of the UP State Chapter of AGOE to this meeting. This year we took over the new office bearers, and we have done. The Kanpur team has done a great program on vulval diseases in February. In March, we had scheduled actually 2 programs, but we could not do because of a lot of other national activities. And also, as Madam mentioned, our dear Amrita had a great loss. And so we could not do it in the month of March. In the month of April, we are here with this special tumor board meeting, because this is the first time that we are holding a tumor board meeting in the UP State Chapter. And we have this with our experts. You have already heard, and you'll be listening to them. And we have international expert for this. Dr. Anita Agrawal is the gynec oncologist who is from Kingston, Canada. And she comes to us. I'm just welcoming her here itself, since the slide is there. She comes to us from the University of Saskatchewan, the Royal University Hospital, and the Saskatoon Cancer Center, where she had been practicing since 2008. And she completed her obstetrics and gynecology residency at the University of Toronto, and then went to the University of Calgary to complete the 3-year fellowship in gynecologic oncology, completing this in 2008. And during this fellowship, she also pursued her master's in epidemiology and received her master's degree in 2010. She also has master black belt 6 Sigma from the Villanova University, USA, obtained in 2011. Her clinical interests include gynec oncology and minimal invasive surgery in gynecologic cancer patients. And I may tell you personally, I have visited her center in 2012, and I stayed there for about 2 weeks. And it was a great experience, learning from the way they treat their patients and all. And she's a great friend, and whenever needed, she is always there to be with us. So I heartily welcome you, Dr. Anita, here for this program. And I'll just request her to say a few words after I just complete. Regarding our association, I just wanted to say that we have added few more members. About 10 more members have been added since we took over. And we are, I would request all the members to further enhance the number of participants in this organization, because it's really important that people who are, all the gynecologists are dealing with these gynecological malignancies in some way or the other. So it's always good to have little more knowledge so that the patients are managed well. And we have, success stories to share here in this platform. So now I would request Dr. Anita to just say a few words here, and then we will start the scientific program. Probably Dr. Rupinder hasn't joined as yet. So Dr. Anita, please.
Okay, good evening. Thank you for inviting me, and thank you for your kind words about myself. So as you are all aware that I have been practicing gynae oncology for almost 14 years or so. So definitely I will provide my input. Majority of my experience in fertility preservation is in atypical endometrial hyperplasia and early endometrial cancer. I do have a couple of patients with early ovarian cancer and some patients with cervical cancer. So I will give you Canadian prospect, how we managing some of these cases, and would like to also learn from you guys how you are doing in India about this fertility preservation.
Thank you, Dr. Anita. Do we have Dr. Rupinder Shekhon on the board? If she's there in the participant group, please add her to the panelist group. And now I'll request Priyanka to take the program forward.
Great, ma'am. Thank you so much, ma'am. So to begin our program for today, I introduce our chairpersons, Dr. Hemprabha Gupta, ma'am, our advisor and someone who's always guided UPSC Agoy. Welcome, ma'am. Good evening. And our second chairperson is Professor Kiran Pandey, ma'am, HOD of Obs and Gynae at GSM Medical College. Ma'am is also our vice president of the UPSC Agoy. I welcome both the chairpersons to take the session forward and introduce our panel experts. I'll be projecting the CV. The first case is by Dr. Swasti, who's consultant at Max Super Specialty Hospitals. So the panel experts for the same are, I request Hemprabha ma'am to kindly introduce our first expert. Ma'am, you're muted.
Am I audible now?
Ma'am, you're audible now.
Yes. So I must thank you, Priyanka, and congratulate the organizers, especially Dr. Saroj and Nisha, for taking this very important topic for the discussion. And fertility preservation is a real problem, and it's a very distressing for the patients once they come to know that they are not able to conceive. So today we have got very special speakers and guests. First is Dr. Bhavna Banga, and she is IVF specialist, Max Hospital, and she is Associate Director, Department of Reproductive Medicine and IVF, Delhi NCR Max Healthcare. She has done MBBS, Masters in Obstetric Gynae from Mumbai, and she has done Senior Residency from Jaipur, and she has done clinical fellowship in reproductive medicine from Gujarat. And she has got advanced training for the infertility and IVF training. And in this webinar, she is very much needed as far as we are concerned with the fertility preservation. She has done special training in the Yale University Fertility Center. She has done MG Gills University, Canada, Monash IVF, Melbourne, Homerton Fertility Unit, London, and Whale Male Reproductive Unit, New York, Royal Victoria Hospital, and Endofert Center for the Male Infertility. She is an expert in the infertility and IVF. And as far as we oncologists and gynecologists are concerned, we will be very much interested in knowing what can be done in the cases, because the incidence of the malignancy is increasing in the younger group also. And taking care of the oncologic benefit, we are also concerned about this fertility also. And once we diagnose the cancer, the patient becomes distressed because they feel that this is the end of life. But thanks to the modern techniques of the technology and treatment, because once they get cured, then they are more concerned about their fertility and their future. So fertility preservation is just helping the couple to make them able to conceive or start the family in near future when they are fit for that. So for that, we have got the case discussions, and Dr. Bhavna Banga will be telling her first case, I think. She will be telling first case, Dr. Bhavna.
Thank you, ma'am, for the introduction. I request Professor Kiran Pandey, ma'am, to introduce our second expert, Dr. Isha Jaffer, for this panel.
Thank you, Dr. Priyanka. Am I audible?
Yes, ma'am, you're audible.
Yeah, so it's my, at the outset, I'm very thankful to Dr. Nisha and Dr. Saroj and all the whole team for giving this opportunity and a very nice initiative which has been taken for Tumor Board. It's my pleasure to introduce Dr. Isha Jaffer. Dr. Isha Jaffer has done her MBBS. Another important thing is she has done her MBBS from GSVM Medical College, Kanpur only, where presently I am also working. So I'm very feeling pleasure about it. But she has done post-graduation from Allahabad Medical College in 2014. And DM Medical Oncology from certification has been 2015. BMJ Palliative Care certification in 2020. Harvard Immuno-Oncology 2020. How academically oriented and concerned with the oncology she is. She has won several awards and prizes. She has 7 publications. And her interest, all cancer and their management through evidence-based and precision medicine using all kinds of systemic therapies, including immunotherapy, target therapy, transplant, cellular. So Isha, I'm very proud of you. You have been doing so much in the field of oncology. You have progressed to a great height, all certifications and everything. And we do all know that the main concern today is of fertility preservation. Although cervical cancer is usually of little later age than early reproductive age, but in presently scenario is this, that age has become a number only. Anything can happen at any age, and therefore it becomes the most important to discuss how to preserve their fertility, because everybody has the right and this is the most important part in the life of a female. So let's see what Dr. Isha and our previous speaker, we discuss this interesting these case presentations in our Tumor Board, and I welcome our expert both from India and from US outside. Thank you.
Thank you so much, ma'am, for the kind introductions. Presenting our first case today is Senior Consultant of Gynae Cancer Surgery, Dr. Swasti at Max Healthcare. Ma'am has done her training in gynae oncology and robotic gynae oncosurgery from Sweden, Germany, and she is a dynamic member of our UPSC AGOI. And without any ado, I would request ma'am to project her slides so that we can take the program ahead.
Thank you, Dr. Priyanka, for your kind words. And at the outset, I would like to thank Professor Nisha Singh. Ma'am has always been very, very supportive of all academic endeavors. And I'm sure in this tenure of UP AGOI chapter, we are going to progress and do much more interesting things. Can you please stop your screen share so that I can share the slides? Yeah, thank you. So I'll just share, and I bring this Tumor Board today an interesting case of fertility preservation in ovarian cancer. I'll first present the case, and then I'll request our experts and Tumor Board members to take the discussions forward, and then we'll wind up and sum up. So every woman dreams of motherhood, and for women's health, I think caring and sharing are two most important things which come hand in hand to their personality, to their lives, as well as to us who treat them. And every cancer patient, every woman who's suffering from cancer, of course, has concerns of delayed motherhood. And I bring to you an interesting situation where there is a 27-year-old unmarried sexually active girl. And this lady is a clinical psychologist by profession. She underwent laparoscopic right ovarian cystectomy somewhere else in 2012 January, which was reported as a borderline serous tumor in the right ovary with no angiolymphatic invasion. The cyst fluid was negative for malignant cells. There were some slides were reviewed somewhere else, which also revealed similar pathology, borderline papillary serous tumor with possibility of microinvasion. However, no preoperative workup in terms of tumor markers or any CT or MRI was available. So there was just an ultrasound, whole abdomen and no markers. And she kept on continuously following without any medical suggestion on her own with an ultrasound every 6 months till 2016 September. And because all these scans were normal, she stopped following up with scans as well. So she never underwent a staging procedure and received no adjuvant therapy. She has history of hypothyroidism and family history of CA, esophagus, urinary bladder, and a head and neck cancer. So she was referred to me in 2020 February with imaging findings by a senior gynecologist. At presentation, she had a 7 to 8 centimeters mass arising from the right fornix and slightly pushing the uterus to the left. Otherwise, all other findings were clinically unremarkable. So the kind of scan also revealed a similar picture with some neovascularization in the right ovarian mass. And MRI also was done, which revealed a 5 centimeter thickened hemorrhagic mass, hypointense 2 to 3.5 mm, patchy signal in the central part with eccentric debris in the anterior and lateral sides. The tumor markers were all normal, CA125, HE4, AFP, beta HCG, and LDH. And again, she underwent after with all these, she came to me, and by which time 8 months had already elapsed for the MRI. So I got an MRI done, which revealed a normal size uterus, a large complex cystic lesion in the pelvis on the right side with mural nodules and papillary projections with no extracystic extension. The cyst size was maximum dimension 8 centimeters and the left ovary was clearly normally visualized. And a CA125 was normal again. Chest X-ray was okay. She got a CT whole abdomen with contrast done on her own because a lot of family of doctors, herself being a clinical psychologist, she would continue to do things on her own. Anyway, upper abdomen was all right. And CT also resonated the same findings as the MRI. So now here we are to the tumor board with a right ovarian complex cystic lesion with mural nodules, a previous history of borderline right ovarian serous tumor, post-ovarian cystectomy, and hypothyroidism. So I request our tumor board experts to give their opinion on how to take this further.
Hello, Swasti.
Yeah.
Hello, Swasti.
Yeah.
Okay, so what was her AMH in this?
So AMH, I will just tell you later. That was after, we had this tumor board discussion. So we're just trying to simulate. So of course.
So I mean, Swasti,
yeah.
Can we just put it to the board that we have already treated this patient?
Yeah, sure.
Yeah.
So, of course, we've already treated this patient. We're trying to simulate how a tumor board works when we are, doing and discussing an oncofertility situation. So, of course, we are very privileged to have this board member comprising of an IVF expert. The experts are gynae oncologists, IVF experts are medical and radiation oncologists on board. So, this patient has already been treated. Bhavna, you would remember her AMH?
She had a good...
This is Anita Agarwal. Can I interfere and ask you a couple of questions?
Sure.
And maybe you can get an idea
of how to
differently.
Yes.
So how old is she now? She's 37 now?
So
at the time when you were treating her?
She presented 2 years back. This was just about when COVID had approached us, February 2020. So she's 29 now. This patient has already been managed in 2020 April. So after
my question will be that the borderline serous ovarian tumor, was it pathology review to confirm it was a borderline serous ovarian tumor?
Yeah, so I'll just take you to that slide again where she had this surgery somewhere outside in 2012, which reported a borderline serous tumor. They had already reviewed a pathology somewhere done, somewhere else. I had never seen her before. And this is the first time that I was seeing her. They had no access to slides and blocks now. So everything else was deposited at 2 separate places. But the first review that was done on these blocks and slides revealed borderline papillary serous tumor, possible microinvasion, and nothing was done on it for the next 6-7 years, except 3 years of 6-monthly ultrasounds. No markers, nothing ever done.
Okay, so I will keep quiet and I will listen how you managed, and then I can tell you if it was
sure.
here, how we will manage this patient, if it was something different. Okay.
So if my tumor board members allow me to tell just what we did, and then quickly all of us can, put in our comments and suggestions. Right. So the challenge was, are we dealing with cancer? Is it invasive cancer? She's a young woman. What about her fertility? So, of course, we have a protocol, and we discussed this in an oncofertility clinic at Max Institute of Cancer Care, which comprises of clinical oncologists, gynae oncologists, as well as IVF experts. And Dr. Bhavna was herself a part of the tumor board discussion and the management of the patient. The critical thing was fertility versus survival. We had a long discussion with the patient and her family. And, again, I would just like to present what are the concerns in this woman. Is she fitting into the criteria for a fertility preservation at the moment or not? Number one. Number two, should we try fertility preservation prior to oncological treatment, or should we defer fertility preservation post-oncological treatment? We had a long discussion about this in our tumor board as well as with the woman, and she was very, very clear. Usually, we do not like to stimulate tumors where, 7-8 centimeter size. You don't want to stimulate the other ovary in presence of a tumor. And but they were very firm. She had an uncle residing in the UK. Both of them, uncle and aunt, were doctors in the UK. So we had a long discussion, and they were very clear that we want a fertility preservation prior to definitive oncological treatment. So we went ahead and did a surgical, first I referred her to Dr. Bhavna, and then of course she worked her up further. We did an AMH, and, I'll just show you what exactly we did, and then we come back. One sec. So we did an AMH. She was fine. She did her scans again. And then we did a cryopreservation, oocyte cryopreservation. She did not have a stable partner, nor was she married, only sexually active. So she underwent a oocyte cryopreservation after stimulation on 25th March 2020. And after one period post cryopreservation, we took her for a fertility preserving surgery where she underwent an exploratory laparotomy. I did not resort to a minimally invasive procedure. I'm sure Dr. Anita will have inputs to this as well. Exploratory laparotomy, right salpingoophorectomy, frozen section, peritoneal biopsies, infracolicomantectomy, bilateral pelvic and retroperitoneal lymph node dissection with preservation of uterus and the left tube and ovary. And intra-op, the left ovary was very, very bulky. In fact, I had to, I reconfirmed doing an intra-op ultrasound because the time elapsed between the cryopreservation of the oocyte and to the entire imaging had been about 6 weeks. So, the intra-op also, the imaging did not reveal any involvement of the left ovary. She just had some peripheral follicles. And intra-op, I called up Dr. Bhavna to say, this is what we found. Unfortunately, I did not click a picture. Otherwise, it would have been really interesting to see something, such a bulky ovary post oocyte cryopreservation. So the frozen section, which was sent during surgery, was borderline serous tumor with no comments on frank invasion or microinvasion, and on the washings were negative. And this was something on the frozen. And then, of course, when we finally got the histopathology report, it was a serous borderline tumor, micropapillary variant involving the right ovary, TNM, PT1A, N0, all nodes, momentum, everything was negative. She was LVI absent, no perineural invasion, and the right tube was unremarkable. All the peritoneal biopsies, nodes, everything was negative. So, of course, we rediscussed this in the tumor board. She's doing well. We've completed more than 2 years of follow-up, and she's under observation. She did not require any adjuvant therapy. So now
I think, Dr. Anita, I would request you to give your comments. I'd be very exciting to hear from you. What is your perspective and how do you manage things there?
So for us, borderline ovarian tumor, we do not consider it as malignant. As you all know, it's not an invasive cancer. And we are not doing any staging for borderline serous ovarian tumor if it is a confirmed borderline tumor. We definitely do not do cystectomy for borderline ovarian tumor. So let us say you had a cystectomy and it came out borderline, we will go back and take out that ovary,
yes,
and have an inspection of the rest of the abdominal and pelvic organs. If there was elevated CA125, we will follow them over next few years. But if that was normal, then we just image the residual ovary. But in your case, when somebody has a history 7-8 years ago, pathology was confirmed borderline, and now she has a pelvic mass. Question is if it is the same ovary which had a cystectomy done,
yes,
or so this is the case for her. But let us say you had a scenario when you had the other ovary involved with this pelvic mass. Normally what we do, that we discuss like this, that we take them back for surgery. We tell them that we are going to remove this pelvic mass because she's young, she wants to have fertility preservation. And we say, we will wait for final pathology, because frozen section most of the time cannot tell you if there is a microinvasion or invasion. Sometimes if this is frankly malignant, they will tell you. So depending upon how badly she wants to have fertility preservation, I have had situation when I had one ovary appeared kind of normal, with maybe just like you were saying, bulky ovary. So I have taken it, removed the mass, got the final pathology with understanding she will need a second surgery, depending upon what we find final pathology. And while the time, I mean, it can pan out in two ways, right? If in your case, it was borderline, for sure, everything was fine. But if it was cancer and you had done this preservation, then she can quickly try to, get on with fertility and have the other ovary watch and all those kind of things. But in this case, when it is borderline, this is how we will do it. So we will offer them a second surgery, most likely. And while they are waiting for final pathology, depending upon how much time we had, and if in Canada is also not everything government funded, and majority of these patients don't have money to be able to have fertility preservation with oocyte preservation or embryo preservation. As you said, I will give you one example of my patient, a 24-year-old teacher who presented with a very large pelvic mass, about 20 centimeters, to a gynecologist. And the other ovary was slightly bulky, maybe 5 centimeters. CA125 was within like 75 or something. Our range is 35 normal. So she got surgery. She had big pelvic mass removed. We left her everything else. Final pathology, we waited. It came as a borderline serous tumor with no micropapillary, no microinvasion. And as you know, now the pathology has changed and we have categorized. There's no borderline tumor anymore, right? They are either low-grade serous cancer or a high-grade serous cancer. So those patients who were borderline tumor with microinvasion are actually called low-grade serous cancer. And so, and then she came back and we got her fertility preservation. She was able to afford it. She had no partner, so she just got her egg frozen. And then we took her back for a second look just to see if the other ovary was still bulky. And we did staging, completed the staging for her. At that time, we were still doing a staging for borderline. So we did complete. And then I followed her and her CA125 started to get elevated and her other ovary started to enlarge. And we were unsure if it is borderline or is it, something else is going on. We took her back again and we did a cystectomy for the other ovary, which usually we don't recommend, but because she has only one ovary and she's still only 28 years old. So we did cystectomy, we did a frozen section of cystectomy. We had spoken to pathologists first, and then pathologists ruled out obvious invasion at that time. And she is continued to, she's still 5 years now, and she has ovaries, she has ovarian function, she's not in menopause, and everything is going well. So that's one of the approach we have taken. I don't want to take too much time, but we'll see. I can give you another input if you have a few more minutes. I had another patient who was confirmed ovarian cancer. But again, she came from a culture where She was not married, was getting married, wanting to get married, and wanted us not to inform anybody that she has history of ovarian cancer. And her parents said, no matter what, she is not going to lose fertility, even if it is cancer. With risk explained and everything, I only took out her one ovary and fallopian tube, left everything else. We did complete a staging. And then she went back home and came, got married, got pregnant right away. I saw her walking pregnant, and then she refused to come back for follow-up. So I'm not sure what happened, but she had stage 1C1, stage 1C1 ovarian cancer, endometrioid type, which we managed conservatively, especially because family really insisted. And I'm not sure what happened to her because I could not follow her.
So, thank you, Dr. Anita. I think in this particular case, Swasti said that there was a doubt of micro-invasion in the previous surgery histopathology that was there. And that's the reason they were concerned about it may turn out to be a frank malignancy this time. And so maybe we can hear from the IVF expert how they handled and what all they did, because that's the part that is exciting. Let us just hear from her.
So thank you, Dr. Nisha. So we had a brain. Am I audible? Yeah.
Yes.
Hello. Yeah. So I think we had a brainstorming kind of discussion with the oncology team. What was my
Dr. Bhavna, your voice is cracking. You have a signal
concern
strength issue.
was that we need a go from the oncologist in terms of I'm at my best. Abhi theek hai? Is it fine? I've just hello.
Yeah, I think you put your video off. Maybe the connection.
Yeah, maybe your signals will improve.
Yeah. Okay. Am I better?
Yeah.
Okay, so we had this brainstorm. My primary concern for any fertility specialist would be a go from the oncologist in terms of the survival, because see, honestly, we don't have a lot of knowledge on the cancer pathologies and all. So we need the team to tell us that what is the survival of this. And my biggest concern into this case was that should we operate and then do the cryopreservation or I mean, hello? Hello.
Yeah, we can hear you.
Yeah. So my concern with Swasti, and kind of we had a lot of clinical debate on this. I was kind of scared, to be very honest, and very apprehensive when I saw that big mass in the pelvis. And I told her, Swasti, are you dead sure that this is not malignancy and it is just a borderline cancer? It's not a high-grade malignancy. So she was convinced, and she convinced me as well, that as per her clinical judgment, I think we should do the fertility preservation and then do the surgical, then undergo surgery.
Hello?
But yes? Hello? Swasti, can you hear?
Go ahead. We can hear you.
Yeah. So my question would be to Dr. Anita, that there was a big debate in my mind what to do, this or that. I mean, should we do a preservation or should we do the surgery first? So what were the challenges when I was doing the fertility preservation in this case? First, I would want to know the AMH of the woman. Okay, so we are just not going. We all know that age is a very important parameter to know the outcomes of the fertility preservation program. But however, cancer is a chronic cachexia process. So sometimes you could have a premature decline in the fertility. Fortunately, into this case, she had a good antral follicular count, which was correlating with a good AMH. In the other ovary, where was the affected ovary did not show any egg reserve. I mean, it meant that the entire ovary was damaged. And the other thing was that was I able to access the other ovary through the transvaginal route? Thankfully, the patient was sexually active. Had she not been sexually active, it would have been very difficult for me to do a trans-abdominal pickup, because the entire around 7-8 centimeter mass was just kind of distorting the utero-ovarian anatomy. So the first thing as fertility experts into ovarian malignancies we see is that go from the oncologist, the survival, what is the egg making ability, and are we able to access the ovaries adequately for a transvaginal oocyte collection. And the other thing is that we usually advise the patient that one needs at least 10 mature eggs to be frozen to have the chance of one healthy life baby. So this is a very important message we would like to tell to the platform, that fertility preservation is not about just doing a tick box. Ultimately, it is like, what are we expecting in terms of the live birth? We cannot do a fertility preservation at a 37-year-old with a very low AMH, and we are expecting to retrieve hardly 3-4 eggs. And out of that, we don't know how many of them are healthy. So when such parameters are discussed, you should have a decent antral follicular count. You should have an IVF specialist who is very, very dedicated into fertility preservation. You are into a program where you have robust infrastructure, where you can have long-term cryopreservation duration, like up to 10 years, up to 15 years, because we don't know when the patients would get pregnant. So that's it. Swasti, over to you.
Just one or two things I will like to add for the benefit of everybody today. I had 2-3 dilemmas in my mind. Number one, she already had a laparoscopic surgery for a borderline ovarian tumor where there was no documentation of use of an endo bag. I was concerned about the spillage. The review had shown a microinvasion, just like Nisha ma'am had pointed out. The third thing is she never, had any markers done prior to cyst removal. So whatever markers we are doing now, I don't know how much justified we are in now following her up with tumor markers. The other thing was, when I started seeing mural nodules on the MRI, I was also, a little bit unsure of the fact that she will be only borderline. She may be a very, very early stage 1A or a 1C, 2 or a 1B. I don't know. It was very difficult. The presence of mural nodules, sort of take you to the direction of an invasive epithelial ovarian cancer more than a borderline tumor. And this was a recurrence happening after 7 years. So when I had this discussion with her and her family, they were very, very particular about the fact that I do a fertility preservation prior to the surgery. And then if there, in case, there is a surface involvement, if it turns out to be 1C, then they did not want a fertility preserving surgery. So the entire reason of this stimulation prior to the surgery was only because of this. And she gave me a consent of a possibility of a tumor rupture prior to stimulation of the ovary, because it was quite a significantly large lesion with mural nodules. We could see papillary excrescences very well. There was a lot of neovascularization. So she said, I don't want fertility preserving surgery. I'm fine with the surrogacy later, and you preserve my oocytes. So we have to also not be judgmental and try and take everybody into the discussion of what exactly is their priority. She says, my priority is survival. I don't want to compromise. I don't want to have a recurrence. I don't want to, so just stimulate me now. I'll take this risk and then let me have a complete surgery. So she gave for a consent for a cytoreduction. Just in case there was surface involvement. So the whole reason this exercise was a little twisted and turned was because of this. And that's why I brought this case here, because this, 2 + 2 is not always 4 in medicine. And we always cannot have a very, very strict guideline towards management of these cases. There will be alterations. There will be a lot of things which will change here and there based on what the woman really wants. So we have to have a participative approach. Dr. Isha, I would also like you to comment on.
I will just repeat the important message that you gave, Swasti, about the pre-operative tumor markers. I think most of us know, but since we are on this platform, so it's important that whenever there is an ovarian mass and we are suspecting, or the imaging is like not very clearly towards benign, and then we should have the tumor markers done. And in the young age, because we think about not just the epithelial but the germ cell tumors also, so we should have all of those tumor markers done. That is one important message, so that in the later on the follow-up, the trends in the markers tell us how is it behaving, how the treatment response is in that sense. So that's one. And the second thing I just wanted to ask here to the experts, that if you said that the patient said that in case if it turns out to be a malignancy, surface involvement, and then she would want a cytoreduction. So even I would like Dr. Anita also to respond to this. So if it turns out to be malignancy and you've done a cryopreservation, is it really, I mean, it is from a diseased egg, diseased ovary that we have got those eggs and this thing? Because many times people have these doubts. That's why I said, yeah. So just bring it out here in front of the forum, that how safe it is to use those cryopreserved oocytes for further fertility. Dr. Bhavna, you are answering that?
Yeah. So Dr. Nisha, honestly speaking, I don't know the answer for this, because this was my biggest dilemma when I was telling.
No problem. Then anybody else?
Can I just make a comment? There are two aspects to the situation. Number one aspect is that, see, we are stimulating the ovaries, but we are retrieving it from the normal ovary, from a normal imaged ovary. And that is all that we know about. We have stopped doing wedge biopsies of the contralateral ovary long back. That's not done. So if on imaging, we are fine with it, we are retrieving normal follicles from that. Now, if it turns out to be an invasive epithelial cancer and she's 27, see, as per as genetic testing, we know that all women with ovarian cancer must have a BRCA1, BRCA2 test. They must have a genetic counseling and testing. I would have subjected her to a genetic counseling and testing. And probably when we are looking at oocytes had already been retrieved. But when you're looking at, creation of embryos, a PGD or a pre-implantation genetic diagnosis could be done at that time if she had turned out to be a BRCA mutation positive later. So that aspect I would have liked to add it in this situation if she had turned out to be an invasive epithelial post histology. But definitely, if imaging is normal, then we are fine to go ahead and retrieve oocytes from the normal looking ovary.
Actually, this was a very, I think this case is very different, because, because there could be a debate between oncologists themselves, as well as the fertility specialists, that would they agree with the oncologists.
Yeah, here it is okay. You've got the final histopath of the second surgery also. Isn't that so, Swasti?
No, ma'am. Yes. We did the oocyte cryopreservation prior to the surgery.
I know that, but now
we are okay with it.
Yeah, you got the report. I was just pulling it up that in case. So fine. Dr. Anita, you'd like to say something on this point?
You guys are quite thinking more advanced way about doing PGD and BRCA testing, all those situations. We do not think about doing BRCA testing and any of those things before making our surgical decision, especially when we are even not sure
after
that is an ovarian cancer. I agree with you that saying if you had done a cryopreservation, then you were not sure if the other ovary is diseased or not. And the other question was, even if the other ovary is not diseased, if the ovary has had invasive cancer, we do worry about this kind of situation. We try not to stimulate the ovary when we are unsure, and we have a large ovary. We usually try, our IVF doctors, they usually say that unless you agree, and as you said that you had a dilemma how to access the other ovary, mass was large. We have the similar situation. We tried. So in our case, we will not stimulate the other ovary majority of the time, unless, as you said, patient is willing to take the risk. You retrieve the egg or retrieve the embryo or whatever you have preserved. You do the final surgery. And sometimes we do take patients saying that if the frozen section says it's invasive cancer, do you want to go ahead and complete the whole surgery, or do you want to wait for final pathology and we take you back? So we have those kind of situations. The only other thing is that when you mentioned that you didn't know if they had used an endocatch bag or not, if there was a spill or not. That's a very good question. But the only thing is, if the patient took 7 years to have a tumor come back, is already indicating nature that is probably not an invasive cancer.
That's right.
So, and if CA125 is normal, obviously we only have 70% of the time CA125 elevated, even with invasive cancer. So these are nothing is definitive, but all those things are kind of pointing. And we also know borderline usually takes 5 to 10 years to recur. So obviously 5 to 10% can become invasive cancer. So keeping all those things in mind, I agree with you all doing the right thing, but sometimes we may just have a little bit different approach about going for a second surgery and have a 7-8 centimeter mural nodules, young person wants to have fertility preservation. You may take approach of laparoscopic or minimal invasive surgery if you really think you can do it. And we do minor small phenestrel, and then we pull the ovary out through that sometimes. So we do operate laparoscopically, but we try to avoid spillage, and then we will do a mini lap to pull the specimen out. So that could be another possible scenario.
I would like to
but
add
I don't
one
think
challenge.
we have a right or wrong exact answer how you went about it. I think we can always think about and go back and doubt ourselves, but I think overall, it was managed quite well.
And we had one more challenge I would like to share, which I faced as an IVF specialist, was that I was quite wary of the ovarian hyperstimulation because the other ovaries still had around 10 to 12 follicles which were growing. So we have to ensure that she should not end up into a clinical hyperstimulation syndrome. So accordingly, we had given her a Leuprite trigger, but that just minimizes the chance of an hyperstimulation. So, every step of the cycle, me and Swasti were very closely following the patient in terms of the response, as well in terms of the size of the other tumor growing. I mean, did we see any sudden increase in the growth of the other tumor? Because trust me, I was just not comfortable doing the stimulation with the mass in situ. But Swasti was the one who kept telling that I'm okay as a cancer specialist. You have to just ensure that the patient stimulates well. She should not go into an hyperstimulation syndrome, and you should be able to retrieve at least 7 to 10 mature eggs. You have that target, rest I will handle. I said, okay, fine. So it was not a very easy decision for me, and comfortably quotient was not at ease when I started the stimulation. And then by the time when we did the pickup and all, everything ended well. So it was fine. So I was constantly following a Swasti that what did she find intraoperatively? What was there with the other ovary? Because ultimately is the life of the, of the patient, which is of paramount importance. That did we over aggressively think about the fertility preservation? So these are the doubts which did come to my mind as an expert. So the fertility preservation is not a cakewalk for everyone, as in even if you are an IVF specialist, because you have to consider so many parameters into such patients.
Yeah, correct. I think that is another important message, that always in oncology, gynae oncology or any oncology, the survival and the disease treatment is the primary thing, and the fertility preservation is the secondary thing. That's always there with all of us. So thank you so much. Any comments from anybody else?
I had a question to Dr. Isha and Dr. Bhavna both. That suppose this was a borderline malignancy, but there can be patients who have invasive cancer, early invasive cancer, and they've undergone fertility preserving surgery, and then they needed chemotherapy. So post chemotherapy, what is the how can we counsel patients, like if we have 1A1 suppose, and we've removed the tumor and 1C, tumor removed, invasive cancer, patient has to go for chemotherapy, but the uterus is there, and we want to tell them that you can still have children. So what are the chances? How can we counsel such patients?
So into such patients, again, the oncology board will come and tell us the survival. And if they are saying that the survival of the other ovary, I mean, the overall survival is good enough, then we do a random stimulation for such patients. Like we don't have to wait. Right. No, not post chemotherapy. Between the surgical.
Post chemotherapy, what is the prognosis?
No. Post chemotherapy, there is no ovarian stimulation. The patient will just not respond. So into such patients, they will do donor egg surrogacy. Donor egg IVF in future if the uterus is still in situ. So do not tell patients that after, like we have extensive cancer program happening across the network. There are some oncologists from different units who connect with us and say that, doctor, we had to do the surgery and then we had to undergo the first cycle of chemotherapy. And now the patient is insisting that before she undergoes the second cycle of chemotherapy, I should be doing a fertility preservation. So the answer is absolute no. She will just not respond to the ovarian stimulation.
Okay, thank you, Bhavna. One question, one comment from Isha here. Isha?
Yes, ma'am. Actually, I think if it's a 1C onwards invasive ovarian cancer, then it's better always. And if the patient wants to preserve fertility, so what is feasible in our setup at least is, because here the patients cannot afford also cryopreservation. So at least in our government like hospitals, it's better to go for leuprolide. GnRH agonist we can start before starting chemotherapy, so that at least the ovarian reserve is protected. Then once we end up
the point to ask you was just that if chemotherapy has been given, whether after that, what Bhavna said, you agree to that?
I fully agree. We cannot isolate over after the chemotherapy.
Yeah,
we cannot.
Right. Thank you.
And in case, so I had in case if someone wants to try, suppose if she's a young girl, so you have to at least wait minimum maybe around 2 years and just see how is, till the time
Yes,
the body is
for the complete ovarian function to come back.
Yeah.
Definitely.
Yeah.
Thank you. Yeah, thank you. So Priyanka, about your question as a gynec oncologist, like this stage 1A tumor, the earlier ones we do a conservative surgery, and then we not always necessary to stimulate them. We tell them to go for spontaneous conception, and many of them do have spontaneous conceptions and pregnancies also. So there the survival is also mostly 90% plus, and then they have good fertility outcome also. So
but what we like, basically we understand that after a surgery, the chance and where a tube and ovary has been removed, so the fertility has definitely gone down. But it's a young patient who wants to conceive, and we wouldn't want to wait too long before giving chemotherapy. So that's where
that's okay.
So there is another.
So no, for the adjuvant therapy, it is in the stage 1A and B. We do not. You can avoid that also. 1C, it's okay. We've discussed that. That's fine. All right. So, if any comments from anybody, otherwise we move to the next case.
So there's one thing which I want to ask in the case that Dr. Swasti presented. Were biopsy samples taken from the pelvic peritoneum, the cul-de-sac?
Yeah.
Must be.
Yes. Peritoneal biopsies, I had shown that omentum peritoneal biopsies, we did an infracolic omentectomy because I was still cross-fingered, because only frozen set borderline of final could have been an invasive cancer.
Yeah, so
I did a complete staging.
Absolutely. That always has to be done. Yes.
Thank you.
And one more thing, Dr. Nisha, I think what really helped in this patient was that Swasti and myself were kind of sitting with the patient into a round table discussion.
We were having joint discussions.
We were having joint discussion. It was of immense help for both of us. Because it is not like one is discussing into her chamber and then we are talking over the phone and then trying to discuss. No, we had the opportunity and we did take those efforts to come down and try to be together for this patient, because these are draining discussions. They are not easy discussions.
Yeah. So thank you so much for bringing that case here, Swasti. Priyanka, we can move ahead or?
Sure.
So for the next session,
I will like to introduce Dr. Priyanka.
We'll first introduce.
Okay, first introduce.
Yes, please. So we have with us, I'm so sorry, I'm sharing the wrong slide. Just give me a moment. I request Dr. Swasti to please introduce Professor Shalini Singh, ma'am.
The chairpersons can do that, Dr.
Yeah, chairpersons can, we request chairpersons, ma'am.
Kiran ma'am.
Kiran ma'am is there.
Okay, Dr.
Yes,
H.P.
I'm
Gupta is there.
there. Yes, I'm there.
Yes, ma'am.
Yes. Okay. It was a wonderful discussion for that first case in a borderline ovarian tumor and fertility preservation. And what I could make out that it is very important counseling of the patient should be done. And there should not be any oval retrieval or any preservation after the chemotherapy has been done, because gonadotoxins are there with that chemotherapy. And whenever we are doing, which I could collect from their discussion, that whenever we are doing, the patient should be properly explained and the good number of the follicles should be available for the retrieval, and the facility should be well versed, and the ART experts should be very much seasoned and experts. So that's how then we can ensure that we have got the good results of the fertility preservation. Now our next speaker is Dr. Shalini Singh.
I'm expert.
She is expert. Dr. Shalini Singh is expert. Can I have her CV?
Ma'am, the CV is on the screen.
No, it's not.
My screen is not visible?
No.
No, it's...
Now Priyanka is visible.
Okay, but
Shalini again is
we
not
have
visible.
Miss-
Shalini is not visible. Only her photograph is there, and she is Professor, Department of Radiology, Radiation Oncology, SGPGIMS.
That is all
Lucknow.
we have received from.
Yes. So this is the only available statement in this photo with this photograph of the Shalini. Now, next, now Priyanka, you will be presenting the case.
Yes, ma'am. I'll just stop sharing this slide and I'll go on to my case.
I'll just...
Yes.
Dr. Priyanka, can I introduce you, please? I think...
Okay.
Yes, I
Just
can
a-
introduce Priyanka.
Yes, ma'am. Please, ma'am.
So,
That will
just
be
a
an honor.
second, ma'am. Just a second, ma'am. Dr. Rupinder has joined. I think she's in the attendees. I request the... may I request the host to add her in the panelists? And yeah, she's put up a comment also. And then we go ahead. Till then, ma'am, please introduce her.
Priyanka, it's my pleasure to introduce Priyanka, my colleague, and she is assistant professor.
Upgraded Rupinder, ma'am. Rupinder Sekhawat, ma'am.
Okay, can I continue?
Yes, ma'am.
So, Dr. Priyanka is assistant professor, Gynae Oncology, Kalyan Singh Super Speciality Cancer Institute. Again, Dr. Shalini.
I'm so sorry. That was my mistake. Sorry.
So she has 3 years training in Gynae Oncology, Chittaranjan National Cancer Institute, Calcutta, Tata Memorial Cancer Center, Calcutta. She has done MS Obstetric Gynae Institute of PG, Postgraduate Medical Education and Research, Kolkata. And she has done MBBS from KGMC. And she has done Diploma in Clinical Epidemiology, Public Health Foundation of India. Peer review of the BMI case reports, BioAccent Journal of the Gynecology. She joined Secretary of the Executive Committee UPSC AGOI, and she is organizing committee member of the UPSC AGOI. So Priyanka, now you proceed with your case.
Thank you so much, ma'am, for the kind introduction. Thank you.
Priyanka, can we hear a comment from Dr. Rupinder? Yeah, she's there.
Yes,
About the
definitely,
previous
ma'am.
case, and then we start. Dr. Rupinder?
Yeah, good evening, everyone. Sorry, I was a little late. In fact, I kept trying to join, but there was some problem. They kept asking me for my identity again and again. Anyway,
Better news. So,
yeah.
your comments on the
I'm
previous
traveling.
case. Okay.
Yeah.
Hi.
Hi. So I think let's proceed, no?
Any comments on the previous case that you want to give?
No, nothing really. All I wanted to say is that, it's all very well talking about ovum retrieval and all that. But even for borderline ovarian tumors, no, I think one should be very, very cautious before you actually try to do any kind of ovum retrieval from a sick ovary. I have spoken to many of ART specialists.
I think this is the
And
dilemma
they
that
are
remains with
skeptical
everybody.
about.
So, ma'am, ovum
They're
retrieval was
skeptical
from the
about using
normal
such
ovary,
a-
not from the disease.
So, yeah, so we don't know how normal the normal ovary is, right?
It's okay. I think let's go ahead for the next case.
Now,
Yes, please. Yeah, yeah.
But this is always in the mind. It's
welcome, Dr. Rupendra Shekhu. It's pleasure to see you here. And Dr. Shekhu is Senior Consultant and Chief Gynae Oncologist, Rajiv Gandhi Cancer Institute and Research Center, New Delhi. Dr. Rupendra Shekhu. She has come here as an expert for this tumor board. Welcome, Dr. Rupendra. So now you, Priyanka, you proceed
Yes,
with your
moving
case.
on to the next case. Thank you.
Yes, yes.
Share screen. So the next case for fertility preservation that we have here is in cancer cervix. It was a 34-year-old lady who had a single living issue, and she was not desirous of pregnancy or any further childbearing. But she was young, and she presented with irregular, painless intermenstrual bleeding, which was associated with passage of clots. It was absolutely painless, and she did not have any significant medical or surgical history before this. Obviously, no addictions. She belonged to a good socioeconomic status, and there was no family history of any cancers. On general examination, she was absolutely fine. There was no pallor edema. She was normotensive. Systemic examination, no other organ disease was present. No other comorbidities were there. On local examination, the cervix was bulky, and the whole of cervix was hemorrhagic, bled on touch. And there was a small growth on the anterior lip of around 1.5 to 2 centimeters, and it was close to the squamous-columnar junction. And the rest of the vagina was normal on examination. On PV, bilateral parametria were free. The rectovaginal septum was free. And the MRI report said that the cervix was heterogeneous and bulky. The cervix was 4 centimeters in size, and there was a small growth of around 2.5 centimeter facing the endocervical canal. This growth was biopsied and came out to be squamous cell carcinoma, non-keratinizing type. So, of course, being a young patient, we took her up for our disease management group discussion, and the decision was taken to take her up for radical hysterectomy because she does not want to bear children, along with pelvic lymphadenectomy. But ovaries were to be preserved because we discussed with the patient that she's young, and if we remove ovary, what the after effects can be, or she would require hormonal replacement therapy. So she consented on getting both the ovaries preserved. So we took her up for a type 2 radical hysterectomy, and bilateral pelvic lymphadenectomy was done. Both the ovaries were transected from the ovarian ligament, and we transfixed them onto the psoas just above the pelvic brim, or rather above the bifurcation of the common iliac, outside the pelvic brim. The histopathology report came out to be keratinizing squamous cell carcinoma, and the tumor was present in all quadrants of the cervix. The size of the tumor was 3.5 by 6 by 1.5 centimeters. There was no stromal invasion. The stromal invasion was 0.9 centimeter, and this was deep stromal invasion. There was no LBSI, no perineural invasion. Right and left parametria were free, margins were free, and the closest margin was 0.5 centimeters. Lymph nodes on both sides, iliac and obturator removed, were all free of tumor. The HSCC staging for the disease was 1B3. So we have operated on this patient, and then we put her up for another discussion in the DMG because two things that we found was a stromal invasion, deep stromal invasion, and the size of the tumor was came out to be larger than what we had expected. So I invite the experts to comment on does this patient need any further management, and since the ovaries have been transfixed, so if you would like to opine on the adjuvant treatment at all, whether she needs and how much and how. So can I invite a radiation oncologist?
So did you put a clip where you had transfixed the ovaries?
Yes, when we transfixed the ovaries, the lower pole, which was there, the lowest end, just below that, we transfixed the clip. However, after surgery and after a month or so,
And they were well above the brim, right?
Yes.
Okay.
Yeah, this patient on the final basically staging was PT1B3 and the nodes were negative. However, the tumor size, as you said, were large. So the chances of definitely the giving adjuvant therapy is there, which includes radiotherapy as well. And including the lymph nodes, which will be taken in the portal for radiotherapy along with the area which is the vaginal vault in this case. She doesn't have LVI, and the other thing is just small stromal invasion. So she doesn't require chemotherapy and the parametrium is negative. The margins are negative. So only radiotherapy will suffice in this case. No chemotherapy.
Right, ma'am. So we had.
Let's hear from Isha also. Isha, no chemotherapy?
No chemotherapy, ma'am.
Okay.
Only radiotherapy.
Correct. Thank you.
So there is this Sedley's criteria that has been followed for a very long time, but there's been a debate and discussion on this, that whether at all, is it necessary for all patients, because probably we are over treating certain patients by giving adjuvant radiotherapy after a radical hysterectomy. So may I request Rupinder ma'am if she could give us a perspective on this?
Yeah, so see, when we talk about adjuvant therapy, we generally refer to the Sedley's criteria. So at least three factors should be complied upon: size of the tumor, stromal invasion, and at least one more. Now, since this patient is, what was the histopathology? Was it squamous cell carcinoma?
Squamous cell, yes, ma'am. Squamous keratinizing, right?
Okay, so that is good. And did they do an HPV on it, whether it was HPV associated or otherwise?
That was not done. HPV was not done.
Okay. So these days, our histopathologists, they always, by and large, they give you whether it is HPV associated or otherwise. The most important thing is that if they give you this this terminology, you can prognosticate. Apart from that, it does not really determine whether you are going to give her any adjuvant therapy or no. And I think in this case, since it's a B3 and full stromal invasion is there, and she's a young patient, I think it's better to err on the side of over-treatment, and giving her radiation would be quite okay. What about the LVSI?
There was no LVSI, ma'am.
It was negative?
Yes.
Okay. And what was the size of the margins? The vaginal cuff?
The vaginal cuff was free of tumor.
No, what was the size of the vaginal?
Margin was 0.5 centimeters.
0.5 centimeters. No, so it's just about there. No, definitely, I think. And paracervical margins were negative, I presume.
Negative, yes.
Okay. And type 3 was done?
Yes, type 2 was
done.
Type 2. So I think she should require, she definitely requires adjuvant therapy. She would benefit from it.
Ma'am, another question is the significance of doing a colposcopy even in a patient which is a diagnosed case of early cervical cancer. I think we are not reaping the benefits of doing colposcopy in such patients. I think we can do it routinely, ma'am. What do you think? How's your experience?
So see, let us be practical. How difficult is it, or how easy it is to do a colposcopy for a patient of cervical cancer when preoperatively?
Right.
I don't think it is that easy. So instead of actually doing a colposcopy, what you can do is you can just apply acetic acid on the vaginal margins. Okay, and mark out the area which you think might be acetovite.
Right.
And then your vaginal cuff should reach that area.
Yes, ma'am.
Always remembering this, that you can also get a dull white in that area, which might be just metaplasia because of superadded infection, which is by and large present in a case of cervical cancer. A 1 centimeter margin is absolutely adequate, though of course this is not, it is not categorized anywhere, but still that is what we by and large look for, because we have to remember that there is a 20% shrinkage after applying formalin and all that. So then it gives you a 8 mm margin as per the pathologist, which is adequate. However, if you're addressing a patient who comes to you with, say, an HSIL or something like that, post-cystectomy, and you want to address the vault, in that situation, it is always prudent to do a colposcopy. And sometimes it is prudent to do the colposcopy in the operation theater with the patient relaxed and a proper extended lithotomy, because only then can you actually view the whole vault.
Right.
Trying to do this exercise in the OPD is really not easy and many times not successful.
Thank you so much, ma'am. I have and the next question to Professor Shalini, ma'am. Ma'am, is there any dosage variation when you have patients post radical hysterectomy, and especially if we preserve the ovary and we howsoever we further we keep it, there is some amount of radiation which will the ovary will receive, is what we understand, ma'am. If you could just
In post-op cases, generally we give a dose of 45 grays, which goes up to, which means you give from Monday, it's a conventional dose from Monday to Friday. And this fractionation regimen is given for 5 weeks. So the total 45 grays is given over 5 weeks. So that you give that in 1.8 gray per fraction. So that's the standard radiotherapy doses which are given. In this case, as I remember, what you said was that the ovaries were transposed to the area where it was outside the
near the bifurcation of the common iliac.
Yeah, so it was where the common iliac bifurcation was. I mean, generally, if we go with the guidelines, because it was N0 disease, that means, so we would keep our radiation volumes where the external and internal iliac will bifurcate, which needs to be seen prior when you're deciding for an ovarian transposition, in this case, in a young patient, prior to surgery. And obviously, where the MRI was earlier not showing any evidence of, large pelvic nodes. And we would then probably would be considering something, the target of radiation to be at external and internal iliac, considering that as a low risk volume as per the EMBRACE, guidelines. So the transposition should then definitely be quite high up above that. So a paracolic, gutter would be better, somewhere near to the target volume, which would be here. In this case, I think it could be close, which needs to be seen from an MRI how distance it is, because once you draw the our region of interest, which is the nodes till that, and then you give certain volume of uncertainty while we give the radiotherapy, it could be that your ovaries are near to the total treatment volume. And as you have expressed, that there could be a scatter dose, and even a small scatter dose, as small as a fraction, like you gave a 2 fraction, could be hazardous in basically killing the oocytes in such cases. So if we are considering in a young patient to preserve the ovarian function, it should be quite high up in the pelvis. For radiotherapy, the radiotherapy volumes needs to be understood at the onset as closely as possible, and then transpose the ovaries.
So for cervix, ma'am, would you, as I understand from your how you've explained it so well, should we then ideally transfix in the paracolic gutters? Because we do it on the psoas.
Yeah, I mean, if yes, in that would be a much safer basically transposition compared to lower down. In case if you're suppose in this case there were some pelvic nodes which could have come positive, micro. So your volumes then radiotherapy volumes will go a little more up, somewhere at common iliac bifurcation. So taking that into the picture, I mean, it would be safer to be at a much more higher in the abdomen area, paracolic.
Right. Right. So I have this diagram. So there are many ways of transposing ovaries, but where these are, of course, for malignancies other than the uterus. But for cervix, as we understand from this discussion, that if we have to transfix the ovary, it should be well in the paracolic gutter, because if lymph nodes come out to be positive, then over the psoas or just above the bifurcation, there are chances that they will get affected. Ma'am, talking of this case itself, would it harm if the patient does not obtain brachytherapy? The dose that you have just told us was received by the patient. She received EBRT, and then there was a delay in taking brachytherapy. So does that adversely affect the prognosis of patient?
See, brachytherapy is must in this case. Two reasons: A, as the vaginal cuff was not properly, that was not complete properly taken out from there. The centimeters there. It was a large volume disease. I would definitely go with external and brachy as a boost in this case to prevent the vault recurrences.
Right.
And at least 2 fractions, which we generally give here in this in this case.
So, ma'am, patients who default on brachy, whether they are post-op or whether they are advanced stage CS cervix, how do we counsel these patients if they come back late? Is there any scope of radiotherapy? What I understand
See, generally, if you counsel the patients at the onset and the beginning, which we do in most of the cases, that only external therapy, especially in de novo patients, that once that external therapy itself is not the complete treatment of cancer cervix in advanced diseases, and we tell them that brachytherapy has its impact in the control. So that has to be told in the onset to the patient, because once the patient gets relief of the symptoms, she thinks that that's the end of the treatment. So that has to be completely counseled to the patient at the very beginning. And once you do that, most of the time we don't find that that's an issue that they don't come. Yes, nevertheless, there are few odd cases who prefer to sit down at home. But certainly a very long gap, 4, 5, 6 months down the line, we would not, I mean, giving is an unsurety whether how much benefit it will have. But if it is a gap of about a month or so, we do sometimes give it, knowing that yes, still there is unsurety in terms of the outcomes. But it is better to give than not to give, and we take in account a little bit the correction factor that this much gap is there, so we can give a little more fractionated doses there. Instead of 3 fractions, we can give little 4 fractions or something like that to correct it.
Right, right. Thank you so much, ma'am. I have another question to all experts. Their opinion on transfixing ovaries laparoscopically or even maybe laparotomy for advanced CS cervix patients, whether we should consider this if we have young patients like this one, 34-year-old, or rather we just let them go for radiotherapy and then give them HRT for the rest of their life. So this is a sort of a debate.
I will give you some comment from my side. This is Anita Agarwal. So for transposition, first of all, we always transposite them in the paracolic gutter. We never try to do any lower, just in case. So avoid that problem. If we are going with the trouble to transposition, then just go as high as possible, actually. And then we put a clip, a surgical clip to localize it. And I'm sure you guys are doing it. Yes. Maybe 1 or 2 clips in case one clip falls down. And the other thing is for advanced carcinoma, as you said, that spread, we find that despite transposing in high up in paracolic gutter, up to 40-50% of the chance there is radiation spread and the ovarian function is interfered. And in this patient, it was not really a fertility preservation, it was the ovarian function preservation. But sometimes we do transposition for fertility preservation to be able to retrieve the egg later on for maybe, not so that they can have, I'm forgetting the term.
Surrogacy?
Somebody else can be,
Surrogacy?
retrieve the egg and.
Yeah.
Anyway,
Surrogacy.
that was one question. And the other question you had was about advanced cancer. The question is how much delay it will cause to start the curative intent treatment. So if we feel that by the time we see the patient, we have radiation oncology, see the patient, plan the radiation, plan chemotherapy, MRI, PET scan in case you are doing it, all these things, we try to start the treatment within 2 to 4 weeks of seeing the patient. If we do not have overtime and we cannot do ovarian transposition,
minimum 1 month.
Yeah.
Minimum 4 weeks gap is there on the day of diagnosis till the patient receives any kind of radiotherapy. I think that is common. This is the minimum in all centers here. That's the
yeah. So let us say that's we try to we try to minimize that, maybe 3 weeks, 2 weeks, 4 weeks. But I think let us say 4 weeks is okay. In the meantime, if you think you can do laparoscopic ovarian transposition, which will not delay radiation, then go ahead and do the laparoscopic transposition. But if you are not able to do laparoscopy and you have to do laparotomy, then that will interfere with radiation treatment start, then you will not think about it because you can always give her hormones. So that is how I think kind of we approach.
Yeah.
Thank you so much. Dr. Bhavna, do you have any experience or anything there is in you've had patients post radiation who are seeking fertility, and or in your groups, how do you have patients and how do you all manage such patients? Do we have Dr. Bhavna with us? Yeah, I think so. This would be interesting to know because, or any experts who can comment upon their experience of patients post radiation if they have conceived after the ovary was just preserved. This would be interesting to know because we haven't seen this much. And Nisha ma'am, do you want any question to be asked?
No, I think what you were asking, like one part, Dr. Anita has answered that even in advanced cases, if you want to, if they're young patients, and that was your question, so that is there. But as far as the fertility outcome of such transfixed ovaries, and if, for surrogacy or something, I don't know, I mean, that I do not have any experience or this thing about. Now, since we took this case for the ovarian function preservation, if you have some slides about the fertility preservation methods in CS cervix, would you like to just tell it like that? Yeah,
yes,
that we can
the other
just
method
give
of
her.
fertility preservation that I have only read and not observed yet, but the experts here must have also performed, is trachelectomy. And this is for patients who want to conceive and for absolutely early stage cancer, stage 1A, 1A2 or 1B1, which is less than 2 centimeters without involvement of endocervix on MRI or frozen section. So the technique, if any of the experts could comment on, because I have really never done this. So of course we would be love to learn this also. And whether they have any experience. Anita ma'am, do you have experience with trachelectomy? I'm sure you have patients there are come with early cervix and then they would.
So where I work, we have a small volume center. I have not done, but I know my colleagues have done it. And I do have patients when I send them for trachelectomy in a center which have a high volume trachelectomy, because you only be doing this surgery if you have a lot of patients, otherwise you lose your skill. And we have patients with simple trachelectomy and radical trachelectomy. And basically they can do vaginal or abdominal. I think you all know about that, robotically, laparoscopically, and they all need to have lymph node status evaluated. So we all do pelvic lymph node dissection, frozen section of the margins of the cervix and the vagina to make sure. And yeah, and then there's also a situation of when we are treating them with neoadjuvant chemotherapy to shrink the tumor. And sometimes they can also be considered for trachelectomy after chemotherapy. Again, with the lymph node status evaluation and frozen section and so forth. And bad outcome is always possible. I had a patient who had trachelectomy, but her tumor was large, 3.5 centimeter. But I think the surgeon decided to go ahead with it. And that time chemotherapy was not an option. It's an old case. And unfortunately, I think anyway, she had a recurrence and she died of recurrent cervical cancer after trachelectomy.
So I think patient selection is very important whenever we are thinking, just like in ovarian we said here, because you mentioned about the lymph node status, very important to be sure that it is a disease which is limited to that area and the size, and it is a micro-invasive disease only. So trachelectomy, we do not get such early stage cases, and that's the reason that we do not have many cases of trachelectomy here.
Yes. Most cases are advanced.
Yeah.
And another option which is there is large loop excision in early say cervix with a large top hat, which is what they say. If Rupinder ma'am or Nisha ma'am might want to just talk about it. And rather than going for trachelectomy, is that not a good option, especially for if it's stage 1A, which we rarely get? We usually don't get such patients. But how bad would that be?
So I have done a few cones, yes, in the CIN3s or not actually stage 1, this thing. So there we do whenever we have, and with the margins coming free, so you can give them. But trachelectomy not for fertility preservation in these cases. Dr. Rupinder? I think she's...
Just give me a minute, I'll just revert.
Yeah, sure. Any comments from the chairpersons, Dr. Saroj?
Trachelectomy myself, I have also never done or never seen, but even the removal of cervical stump after a few cases who have already done hysterectomy and cervix they have left because of previous 2 cesarean or like that we have done, and even conization in cases where CIN 2 or 3 even, but not in malignancy. That practically not.
Anybody else for any comments? Swasti?
Yeah, Dr. Swasti, please, if you have any experience with fertility preservation in CA cervix.
So, unfortunately, cervix still either we are getting in CIN 3 stages or we're getting very advanced. Very early cervix is beyond our domain at the moment still.
So time will come when
probably I'm quite happy to have them in CIN 2 and 3 rather than to have a cancer.
Actually, I'm doing an OPD as well. So it's like this, that cancer cervix, just 2-3 points I just want to make as far as fertility preservation is concerned. Most of the things have been discussed quite comprehensively. Only thing is that when, number one, we try not to conserve the ovaries when the histopath is an adenosquamous carcinoma, or especially not if it is an adenocarcinoma. That is one. Secondly, once we transpose the ovaries, we have to explain to the patient that there is a chance of these ovaries forming a cyst. You can have an ovarian cyst in as high as 25% of the cases. Thirdly, that thing about trachelectomy and all, I have done a couple of trachelectomies, but like somebody else also just now said, getting a stage 1A, 2, 1A, or even a 1B1 cancer, they're few and far between. And even if they are like that, the kind of clientele we have, they would much rather have a hysterectomy rather than any kind of fertility preserving surgeries, because the word cancer, they're so scared of that.
Yes.
So I think that pertains to our Indian experience more than the Westerners. So though we have done a couple of parametrectomies, that is that after a simple TH-BSO has been done and the patient has come back to us with the report of cervical cancer, we have done parametrectomies in a couple of patients. So fortunately, in all 3 of them, the 3 cases that we did do, the parametrium was negative. The parametrium must have been soft and must have been uninvolved. That is why we were able to address the parametrium at all. One thinks of it like this. Had the parametrium been involved, or in any case, even some induration, we would not have been able to do a parametrectomy at all. So that is as far as doing any kind of, surgery for early cervical cancer cases are concerned in our experience. Thank you.
So I will just have one comment. I agree with Dr. Sikhan saying ovarian preservation, we do not recommend for adenocarcinoma. In case we do recommend, the only reason we do not recommend that is 5% chance that ovary may be involved with adenocarcinoma. If you are leaving the ovaries, they need to have every 6-month ultrasound to follow the ovary. And if ovary, there is a doubt that ovary is abnormal, then you may have to take it out. And the other thing about stage 1A1, we do have sometimes when we have done a leap or cone for stage, CIN3. And when we have final pathology, this is stage 1A1 cancers and margins are clear, and we have followed them for fertility preservation. We keep a close eye on them. We do ECC, and as long as there is no evidence of ongoing any issues, they can continue to have, keep their cervix intact.
Right.
Yeah, see, as far as following up for the ovaries is concerned, I'm talking in terms of adenocarcinoma, it is very difficult to follow up these ovaries because number one, of course, anything with the ovary will be asymptomatic. Secondly, imaging. You need an absolute expert to be able to detect these ovaries on ultrasound. And so also the CT scan, because like our previous speaker very rightly said, that the correct place to transpose the ovaries is the paracolic gutters. And to be able to trace a subsequently normal ovary in the paracolic gutters by imaging is an exercise in itself. And the person who's doing the ultrasound or the CT has to be made aware that please look for them, and only then they would. And finally, when they are seen, they are cystic. So all these things have to be kept in mind.
So if we don't have any more comments from all experts and chairpersons on this topic, I would just simply summarize that in cancer cervix, with the perspective, putting it in perspective in India, we don't get many patients who are candidates for fertility preservation. All we can do for some patients, if they come with any stage cancer cervix, we can do ovarian transposition, ovarian preservation we can do. Trachelectomy, most centers have not much experience because, of course, most patients they have are advanced CA cervix. And while screening, we may come across early microinvasive disease. So, as Dr. Anita said, that if we follow up such patients, still so far as their experience is that it does not, if the margins are free, the chances of survival are good for such patients. So we've had a good discussion, and that's all from my end. I request this secretary and president if they wish to have any final comments before we put in the vote of thanks.
It was a wonderful presentation, and we have learned a lot because for this cancer cervix, functional preservation and fertility preservation are the two aspects. As Dr. Rupender has already said, when the radiation therapy is the primary treatment, most of the cases, because if they are not that well advanced, so the radiation dose is unavoidable to affect the preserved ovary. So it has to be put or transfixed as high as possible, but the patient should be explained the consequences of that ovarian fixation. Maybe cyst formation, maybe even malignancy formation also. So it is very important to counsel and review again and again for this type of the preservation, functional and the fertility preservation. We should think over all these things because the cancer cervix is now occurring in a very younger stage also. Very younger patients are suffering from the cancer cervix. So we require a lot of investigations or experimentation for this preservation.
आपकी आवाज थोड़ा और पास से बोलिए, थोड़ा कम सुनाई दे रहा है मैम, सॉरी।
कम सुनाई पड़ रहा है।
थोड़ा बेहतर हुआ।
नहीं, सुनाई पड़ रहा है।
हाँ, ठीक है मैम।
Yes, I said that functional and fertility preservation are two aspects. And as Dr. Rupender has said, that whenever we transfix the ovary, it should be as high as possible, not just above the brim. And as it was a prior concept that it should be transfixed or transpositions over the psoas muscle or above the brim, because you don't know how far this radiation dose will be affecting the ovary. So the patient should also be counseled that she can have the problems or the complications or sequelae of this preservation, may be functional or maybe fertility, cyst formation, even malignancy formation, or the ovary may recede back to its original position. So it is very important for all these things. So this is what, as a ordinary gynecologist, I have to say, because the experts have discussed it a lot, and I just wanted to see the trachelectomy, because the experience of this trachelectomy is very limited as far as I know. So I don't know what are the sequelae and consequences for the fertility preservation, although it's mentioned in the books. But what we are practically doing, or what it is well tried and tested procedures we should do, and keep on looking for the further advances in this preservation. Now, Kiran, will you like to say something, Dr. Kiran?
So Priyanka, please stop sharing the slide. We can see everybody's face nicely.
Kiran.
Yeah.
Hello.
So videos.
Hello, MD, namaskar. Yeah, it was very interesting discussion, and actually the most important thing which I was thinking about, you have already summarized it, that in cervical cancer or maybe some other cancer, the most important thing, we don't get it into the very early stage. As Nisha was saying, either CIN is there or patients do come into advance, unless and until it is an accidental finding, you do something and then you find the carcinoma in situ. I found one or two. Otherwise, it is most of the time it is the advanced stage. So that is the problem of our taking these steps towards the fertility preservation becomes quite difficult. We don't have much experience. I only had, in fact, I would say long back, must be around 15, 20 years back, when I got one patient of the stage 1A, you would say. That time that classification was also, the figure staging was also a little different. So that time where I had saved the ovaries, and luckily when I sent for tumor board discussion into the JK Cancer Institute, they did not advise for adjuvant radiotherapy and chemotherapy, and she later had fertility, actually not the exactly issue directly, but she went for the oocyte retrieval later on, but that is quite long back. So that's the only one case I do the gynecology practice. The rest of the patients have always dealt into the later stages when we have to do the type 3 or type 2 hysterectomies. So that is one thing. And the one thing which I noticed Dr. Rupinder said, and which is very important to note here down, is that if it is an adenocarcinoma or something, then don't try to. This was the important point, which message even I was not very particular about it. So that is the thing, and both the discussions have been very good. Congratulations, Dr. Saroj and Dr. Nisha, for taking this initiative. They will be more updated by this.
Had nice discussion. By input of all the panelists and chairpersons was great, and I especially thank our guest faculty, Dr. Anita Agarwal, Dr. Rupinder, and Isha, Shalini, and Bhavna. And I hope that in our future programs also, Dr. Rupinder, can you listen? in our future programs also, we
Yes,
will
yes, I'm
have
listening. Thank you.
yes. In our future programs also, you will be available for us, and we will
Yeah,
be
sure.
listening you, Dr. Anita, Dr. Fitness, which was
Yeah,
very
yeah.
nice
Thank you so
to
much.
listen you all.
Yeah, yeah, you have to thank Nisha. I can never say no to her actually. So that's even though I'm terribly busy, but since it was Nisha, so I've come. Thank you so much for having me here. Thanks a lot. Thanks, Nisha. Thank you, everyone.
Yeah.
Pleasure.
Thanks to Nisha.
Yeah.
Thank you. A special thanks to Dr. Anita, who has joined in early morning. I'm sure it must be 4 o'clock in the morning or something that she has joined with us. Isn't it so?
No, 6.
6 now, no, but you
Now
started
6.
at 4. Yeah, so she really has been so sweet to accept our invitation for coming into this state chapter. And I do understand that people who are really interested into gynae-oncology and fertility preservation, it's a little higher level discussion, a little bit from general gynecs, but gradually we are building ourselves up and we are learning to know more about things, and so that we can give these benefits to all our patients who are coming. So I think that's a good move. We just thought that let's have it like this time. So we will keep having all types of programs where we have some basics and we have some advanced, so that will be there. And in the same month we are going to have one more PG mentoring session. We have this month coming up from Agra, so looking forward to that. If any more comments from the seniors, then Priyanka can put up the formal vote of thanks. Any more comments?
Very good.
I really congratulate you, Nisha. You're taking a good move.
Everyone, and awareness is very important. So everyone has become sensitized for these advances, whatever are being done. And it is for further your board or further webinars. More and more, and will be more. So thank you very much for your efforts and selection of the topic. Thank you, Dr. Saroj and Nisha.
Thank you so much, dear chairpersons, Professor Hemprabha Gupta ma'am and Professor Kiran Pandey ma'am, for guiding us, for your valuable inputs and enriching this session. Thank you, our experts, Dr. Anita Agarwal from Kingston, Canada, and Dr. Rupinder Sekhu, our Secretary AGOI from Delhi. Thank you, Secretary UPSC AGOI, Professor Nisha Singh ma'am, for the idea and your enthusiasm that you add to everything that we do here. Thank you, President UPSC AGOI, Professor Saroj Singh ma'am, for being there, guiding us, keeping us under your wings. Thank you, Dr. Swasti, for bringing in this interesting topic that we discussed today. It was very valuable, and most practitioners, oncologists or not, experience and come across these patients. Thank you, Dr. Bhavna, for giving your inputs, which were very interesting and something that we always need when we have young patients who are desirous of childbearing. Dr. Shalini, thank you so much for your inputs on how we should be looking at patients who are young and come in with early disease, and how radiation can act adjuvantly, and how we, while operating on such patients, what things we have to keep in our mind. Thank you so much, ma'am, for your valuable inputs. Dr. Isha, it was wonderful having you, as usually, to have you on our clinical and academic sessions, and your inputs were very interesting, and we hope that in the future we'll have you again. I thank Walter Bushnell for providing us this platform, for bringing us in time and asking us time and again, let's please start. And it was a wonderful experience to work with you. On behalf of UPSC AGOI, I'm grateful to all who made this possible. Our delegates, the most important people without whom the show would not have been so lively. Thank you all delegates, and please join us next whenever we are up and above. Thank you.
Thank you,
Signing
Thank
off
you,
from
Priyanka ma'am. Thank you. Ma'am, this is Ranjit, marketing head. So I want to give a gratitude to all towards being associated with such a learned panelists for this important topic. And Walter Bushnell stands committed for such kind of scientific feast. As always, we stands committed to give us a chance to get associated. Thank you, ma'am.
Thank you so much.
Thank you.
Thank you. Thank you, Nisha ma'am. Thank you.
Thank you. Thank you, Walter Bushnell, and all the participants. Actually, we had separate links, so we can't have a picture with all of them together, which I wanted. But Dr. Shalini, if you're there, put on the video so that, and Dr. Rupinder, you too. Dr. Kiran, I've taken few, but Dr. Shalini, okay, at least I'll take this much. Some people have left.
I'm trying to edit video, but there is some glitch in the video, activating the video.
Okay, okay. So thank you all once again. Meet you again.